Now's the time to finally realize we the people must make some choices. If we want single-payer health care, now's the time to raise our voices.
Welcome, everybody. We're glad to see you, and we should have an interesting talk tonight. I'm Sarah Weinberg, but commonly called Sherry. I'm a retired pediatrician, and I've been president of PNHP Washington for over 10 years now, and also the treasurer, manages the bank account.
I'd just like to acknowledge that we are on the ancestral lands of the Coast Salish nations, specifically the ancestral lands of the Duwamish, Suquamish, Stillaguamish, and the Muckleshoot people, whose people still steward this land today.
This meeting is being recorded and it will be available on our YouTube channel in a couple of days. And I'll be sending out a meeting report with a link to that once it's up there. So our website, which has been pretty lousy for the past few months, in the next 2 weeks or so, we're going to have it going full bore since we hired somebody who's an expert and who does the one for Healthcare for All Washington. She's going to be doing ours too. And I think probably within a week or so, it's going to look a whole lot better. We marched in the Martin Luther King Day Parade on Monday, and proudly with our banner. You see that?
Ah, gorgeous.
Finally, our board has some changes, and we've had an influx of students for a national health program. There's a bunch of them are around here, and the DO school and the UW school, and hopefully we'll have some in Eastern Washington there. I see Chris Curry's here tonight, and I think Hugh stopped by there a few weeks ago. So I'm hoping we can have some more interaction with those folks out there and help them get their chapter started. SteveKemble is our speaker. So he's been around a long time. I think not quite as long as me, but anyway, he's a fountain of knowledge and experience. He's in Honolulu, he's an internist and psychiatrist, and he's been practicing 35 years primary care clinic there. But he has lots of administrative and health policy experience setting up health plans. He was appointed to the Hawaii Health Authority in 2011 and charged with designing a universal healthcare system for the state there to cover all residents in Hawaii. But when the Affordable Care Act came along, that was dissolved to make space for the Affordable Care Act to state. So he hasn't retired, at least not politically. He serves on the board and also chairs the policy committee for both the positions for the National Health Program, National, and the one payer-based organizations.
The case for removing the middlemen from Medicaid, which is one of the current PNHP campaigns, and I was a co-author of the PNHP report on removing the middlemen from Medicaid that was issued in September. Nothing to disclose. So deprivatizing Medicaid. By the way, the slides can be used as a handout. They pretty much cover everything I'm going to say. So if you want to save the slide deck or a PDF of the slide deck, you're welcome to use it as a handout. So unlike Medicare, Medicaid implementation is under state control, which means it is an incremental step that a state can do that would help get rid of insurance companies in healthcare and restore the autonomy of the physician-patient relationship. Original Medicaid was a state-administered, so-called unmanaged fee-for-service program. And federal law has two alternative ways to organize Medicaid. One is with capitated private managed care organizations, or MCOs, which requires a Section 1115 waiver from CMS and state oversight. There are requirements the plans are supposed to meet, which they often don't. And the other is primary care case management, in which primary care practices are paid something extra and empowered to manage care instead of insurance companies. North Carolina and Oklahoma pioneered this model until 2 or 3 years ago, when their Republican legislators went over to managed care companies because of ideological reasons. in spite of the fact that their programs were among the most successful in the country using primary care case management. And then there's managed fee-for-service, which is developed by Connecticut. It's very similar to PCCM, but it's the same idea where you have primary care practices managing care and they're paid extra to do so. And you also add community-based resources to enhance their ability to manage care beyond the doctor's office. And because this is a fee-for-service program, it doesn't require any waiver. All they had to do was cancel their Section 1115 managed care waiver and go back to original fee-for-service, but enhance it. And that's why they call it managed fee-for-service, because it isn't unmanaged. It's just managed by the doctors. So the problems with full risk MCOs are that they are all capitated fiscal intermediaries, which means they have incentives to upcode and skimp on care and to profiteer. Their administrative overhead is in the range of 13 to 20%. They impose burdensome and senseless prior authorization requirements and formulary restrictions. There are problems with claims processing and unreasonable claims denials and delays, and widespread refusal by independent doctors to accept new Medicaid patients, especially in primary care and psychiatry. I don't know how it is in Washington, but Hawaii used to have almost universal participation in Medicaid by primary care and psychiatry, and after managed care came in, they all just got out within a few years, and now it's almost impossible to find a doctor who will take a new patient with any of the Medicaid plans. They have obviously false network adequacy reports, at least here in Hawaii they do. They claim, well, United Healthcare's reported network adequacy, they'd have an annual external review. It claims that they have 1 to 22 ratio of primary care doctors to patients. If that were the case, then every single primary care doctor in Hawaii would be seeing nothing but United Healthcare Medicaid patients full-time and no other patients at all. And that's obviously ridiculous because nobody can even get an appointment with any of the doctors if they have United Healthcare Medicaid managed care. Incomplete and misleading financial performance reports. They disguise a lot of administration as healthcare. They contract to subcontractors to do all kinds of things and call it all healthcare, even though it's administration. So the medical loss ratio figures they give the state are blatantly false. There have been multiple sanctions nationwide against Medicaid managed care companies, and there's ongoing investigations of United Healthcare for extensive Medicare Advantage fraud, which has been in the news within the last few days. And in Hawaii and most other states, once they go to managed care, then their costs rises faster than it had been under fee-for-service. So payment systems for healthcare, and this is something that I've been really interested in for a long time. If you see fiscal studies of managed care proposals, they usually just assume the same payment system going forward, and they come up with small savings. But an unnecessarily complex payment system adds about 15% to the total healthcare cost of our system. And a simplified standardized payment system could save 15% off the top. There is no other profession where you have to spend 15% of your revenues just to try to collect the bills. So the current policy fad is value-based payment, which assumes that excessive costs in the U.S. is due to presumed incentive with fee-for-service to deliver excessive and unnecessary care for financial gain. Therefore, we must move away from fee-for-service and pay for value, not volume, using capitation and pay for performance. But we never had more volume of care compared to other countries, even when everyone is paid for fee-for-service. So this whole rationale is based on a lie. Abuse of fee-for-service occurs mostly with corporatization of medicine, when you get corporate entities buying up hospital practices or controlling hospital or doctor practices or buying them up, then they pressure the doctors to abuse fee-for-service. Independent primary care practices are the least likely to deliver excessive volume of care, yet they're the primary target of value-based payment. So let's look at what's happened to fee-for-service over the past 50 years. From 75, I graduated from medical school in 1973. So from 75 to 97, I was in private practice, and most doctors were in independent practice Everyone was paid with fee-for-service. I knew of some abuse of fee-for-service with certain procedural specialists, especially those employed by hospitals, but I never saw signs of abuse of fee-for-service from primary care specialties. So in 1990, CMS added what I consider to be appropriate general documentation guidelines, which is basically following the medical model. You need a reason for the visit, interval history, relevant exam, lab and imaging, assessment, diagnosis to justify medical necessity, a plan, and a signature. I consider this to be entirely reasonable and appropriate. But then in 1992, they introduced the resource-based relative value scale fee system, which tries to assign a relative value to each of thousands of procedure codes. There's a resource-based update committee convened by the AMA, mostly consisting of specialists. They have 4 components of fees: work, practice expense, malpractice costs, and a geographic adjustment, or GIPSY. Had been a sustainable growth rate formula that says if healthcare spending goes up too fast, they're supposed to cut fees to compensate to make it equal to the general cost of living increase. And this resulted in escalating annual threats of pay cuts. And budget neutrality rules pit primary care against specialists. So if you raise primary care pay, you have to cut specialist pay. And the result was a widening gap between procedural and cognitive specialties. In the mid-90s, many states started privatizing Medicaid with full risk managed care plans. And by early 2000s, 3/4 of Medicaid beneficiaries were under private MCOs. The result, proliferation of prior authorizations for both visits and drugs, declining physician participation, increasing reliance on urgent care, ER, and hospitals for care, and accelerating cost increases. In 97, Medicare Advantage was started with private full-risk capitated plans within Medicare in competition with traditional fee-for-service Medicare. The rules were skewed to favor the Medicare Advantage plans. This is not a level playing field, and they have relied on gaming the payment system for profitability. And in fact, if you were to actually have a level playing field where the benefits had to be the same, the fees had to be the same between Medicare Advantage and traditional fee-for-service Medicare, all the Medicare Advantage plans would be out of business because their administrative overhead would drive them out of business. So they have exploited all the ways that you can exploit the payment system. So you have, with Medicare Advantage, a lot of new prior authorization requirements, whereas fee-for-service Medicare uses very few. And all the forms of gaming listed in the previous slide: upcoding, cherry picking and lemon dropping, denying care, and using unspent capitation funds for profit. So CMS began requiring escalating unreimbursed administrative data from physician practices. Also in 1990,
Seems like it froze up, Stephen.
an evaluation. What?
Oh, you kind of froze up for a little bit.
Oh, okay. I'm just saying that this is a pay for documentation scheme where you add up all these elements in your note, and that determines how much you get paid. And in our psychiatric practice, the length of notes tripled overnight when we were put on this system. You get gaming. Wait, I'm on the wrong slide. Yeah, accuracy of notes deteriorated with cloned information not updated for accuracy, false information claiming you did things you didn't do, lots of useless information added, charts became very difficult to read, you couldn't tell what's real and what wasn't, and this is more unreimbursed time for physician practices. Then in 2004, CMS noted that Medicare Advantage plans were gaming their risk pools with cherry picking and lemon dropping, so they had a risk adjustment formula based on demographics, but that only predicted individual risk with 1% accuracy and wasn't any deterrent to gaming risk pools. So they added diagnostic categories to the hierarchical condition categories risk adjuster, and that increased the accuracy for an individual from 1% to 11%, which is still nowhere near enough to deter cherry picking and lemon dropping from within categories. The HCC tied payment to the details of diagnostic coding for the first time, requiring maximum diagnostic specificity, and Medicare plans were quick to exploit upcoding to gain the formula for profit. So from 19, they combined evaluation management with psychotherapy in one code. We basically used 4 codes: a 1-hour visit for new evaluation, up to 2 visits, 45 minutes of combined psychotherapy and E&M, 30 minutes combined psychotherapy and E&M, and a 10 to 15 minute visit for stable patients needing only a check-in and prescription renewal. And the doctor got to choose the time needed for each payment. The 2030 implementation scheme is primary care practices, and the length of notes in our practice more than tripled, and the notes filled up with garbage, and we had to spend a lot more time on documentation, which invaded both patient care time and personal time, and practice became much less efficient. Then the Affordable Care Act came along, blaming high cost on fee-for-service driving unnecessary care, which, as I said, wasn't true. But they blamed it on that anyway, and they promoted value-based payment.
Pick it up again. Steve, I wonder if, oh no, you can't turn,
And it's supposed.
can you turn your camera off, and will you still share if you do that? Maybe then you'll stop.
Let me try that.
I don't know. Nah, that doesn't work.
Uh,
Oh, there, that works. Okay, maybe.
Okay.
There we go. Okay.
We can try
works.
that.
Yeah, try that.
Okay. So the Affordable Care Act was all in on value-based payment and discouraging fee-for-service, and promoting what they call advanced payment models, and relying on financial incentives to manage doctors instead of trusting their intrinsic motivation. So they came up with a whole series of acronyms for advanced payment models, all of which require some form of capitation or partial capitation of organized groups of doctors and hospitals, accountable care organizations, direct contracting entities, ACO REACH, Maryland total cost of care budgeting for hospitals, advancing all-player health equity approaches in development, etc. Meanwhile, in 2015, the macro law was repealed. They repealed the sustainable growth rate formula and replaced it with MACRA, which says that doctors must either join an APM, advanced payment model, or submit all this detailed computerized data on utilization and quality metrics, which is called MIPS, or else CMS will progressively reduce your fee-for-service fees starting in 2017. In my own private practice, that happened. 2016 is the year I turned 70, and we shut the practice down because our fees were starting to get reduced. Budget neutrality's rules remain in force, so they're still pitting specialists against primary care, and this means even more unreimbursed time is required. Then in 2021, CMS started allowing time-based evaluation management coding instead of pay for documentation. So you could base your charge on the time that you spent with the patient plus time spent on documentation and care coordination on the same day as the visit. And you didn't need to count elements in your note, although some practices were afraid to stop doing so for fear that CMS would start denying claims if they based it only on time. But actually, you could do that. I started doing that myself because I was familiar with time-based coding from before 2012. And it worked fine. Now, you will note that with the exception of time-based E&M coding since 2021, every one of these changes to fee-for-service since 97, when they introduced Medicare Advantage and when Medicaid managed care was coming in, was implemented to enable capitated corporate intermediaries to obtain the data they needed for risk management and for their managers to pretend they could manage care better than doctors. Every one of them was for the benefit of capitated intermediaries. Why do corporate interests prefer capitation and demonize fee-for-service? Well, capitation is not the same as a budget. It seems like it might be the same, but it requires members in order to pay per member, which establishes a separate risk pool. And then you have incentives to game the risk pool with cherry picking and lemon dropping. You need risk adjustment, which is gameable with upcoding. You can profit by skimping on care, which happens with both necessary and unnecessary care. And there's an attempt to counter that with quality metrics. And a capitated plan can grow their business with administrative complexity and keep any unspent money as profit. So it's an invitation for profiteering. Waste, fraud, and abuse due to corporate profiteering far, far exceeds any abuse of fee-for-service by doctors and hospitals prior to privatization of Medicare and Medicaid. You've all seen this famous PNHP graph of the growth of managers in red and physicians in green at the bottom since 1970. And this is CEO pay from the major health insurance companies in 2024. That's why they want capitation. So what is the payment sweet spot? My opinion is that we could minimize costs for the whole system with simplified, standardized payment. Use the fee-for-service time-based codes that are now allowed by CMS, similar to what we had in psychiatry prior to 2012, but now including time for documentation and care coordination, which is really helpful. Go back to the documentation requirements enforced prior to the RBRVS system, which is basically you just need to document the medical model, and eliminate capitated fiscal intermediaries, which eliminates profiteering, no need for pay for documentation, no need for detailed diagnostic coding or tying diagnosis to payment. Upcoding is not an issue, and there's no value-based payment with high administration and perverse incentives. And this is doable under current Medicare law right now.
Oh, right.
Time-based fee-for-service has less than 2% administrative costs for claims processing. Documentation is focused on patient care priorities, not billing or pay for documentation. Diagnosis is for medical necessity only and not tied to payment. It pays for the value of the time and expertise of the professional performing a procedure, which is the same as for any other profession, instead of trying to assign a relative value to each of thousands of procedure codes. It's incentive neutral for choice of treatment. Doctors can choose the time needed and are not punished for taking on more complex and time-consuming patients. And it makes billing and collections very simple and minimizes overhead. With a properly designed fee-for-time system, you would enter the codes at the end of the day for the visits that you saw. The payer would add up the times and cut you a check every 2 weeks. You would not need to hire any billing and collection staff to do that. You or your administrative assistant or medical assistant could do that at the end of the day in 10 minutes. Okay, Connecticut implemented managed fee-for-service. They fired their Medicaid managed care plans in 2012. They hired one of the former managed care plans, which is a local nonprofit plan, as a non-risk administrator for 15% of the administrative costs of managed care organizations. They raised primary care fee-for-service rates to Medicare level, and they added an additional care coordination fee for patients whose primary care practice was designated to coordinate their care. And they also added community-based programs for high-risk, high-cost patients and special needs populations. The result was an immediate 13% of the budget saved from non-risk administration. They invested 3% back into improving primary care pay and adding community-based programs and resources. They got a 33% improvement in physician participation in Medicaid from the first year, and improved access to primary care was followed by declining ER and hospital utilization. And 5 years out, they are spending 15% less per beneficiary than during the last year under managed care. This is the only reform in the US in the last 50 years that substantially reduced costs, improved access to care, improved physician satisfaction, all at the same time. Behavioral economics has shown persuasively that external financial motivators can undermine and corrupt the kind of intrinsic motivation that all primary care providers bring with them when they choose a primary care career. No one would choose a primary care career because they want to get rich. They all have intrinsic motivation. Financial incentives require added administrative costs for both the payer and the provider, but intrinsic motivation would cost the healthcare system nothing. We should be funding resources to support management of care by primary care practices, not financial incentives to try to manipulate them. Community-based interdisciplinary teams to assist primary care in managing high-risk, high-cost, and frequent ER utilizers in the community means that the team would help ensure the patient stays on their treatment plan, takes prescribed meds, has transportation to their appointments, is monitored at home, etc. This does result in reducing ER and hospital utilization. And you also need special programs for patients with serious mental illness and substance abuse, and geriatric services, including daycare programs, home visits, and consultations. Those are separate special needs programs. Community-based. I think Connecticut could improve their results further if they added community-based specialist consults to back up primary care, following the collaborative care model, which was developed for psychiatry at University of Washington. The way the model works is you have a team with a part-time psychiatrist and a full-time care manager, who's usually a social worker or could be a RN or APRN. And if you get a consult from a primary care practice where they have a patient with a psychiatric problem, the care manager contacts the practice within 1 to 2 days, business days, and gathers a history from the primary care doctor and from the patient, and usually has access to the chart, or else has to get faxed notes from the chart and other data from the chart. And then they present the case to the psychiatrist in our weekly interdisciplinary team meetings, and then the psychiatrist gives the primary care practice patient-specific advice on how to manage that patient, and the team follows up as long as necessary until the patient reaches stability. And I was a pioneer in this model in Hawaii, but it was developed at UW. And it really does reduce referrals to specialists for direct care and reduces preventable ER and hospital utilization significantly. That's been shown all over the country, and we demonstrated that with our own data and our practice in Hawaii. If you could do the same model for a whole array of specialist consultations, anything that doesn't require an imminent procedure, you could have a community-based team which was consulting to primary care practices, and the specialist be telling the primary care doc how to manage the patient, and only when the patient really needed it would they get referred for direct care. You could then have lean primary care practices who didn't need to hire a bunch of care coordinators in-house, but would rely on these community-based programs and specialist consults to deliver specialist-informed care in any setting, including rural and underserved areas. So this is more on the collaborative care model. We finance it in a unique way in Hawaii, because what we did, instead of using the fee-for-service procedure codes that CMS developed, which require that the primary care practice submits a bill, collects the copay from the patient, and then reimburses the psychiatry team, we got all the insurers in Hawaii to fund the program directly. And we do no fee-for-service billing, and we're not paid with capitation. We're paid with a budget that's based on our cost of operations, and each insurance plan is contributing their share of our caseload to our budget. And we've been able then to offer our services to primary care practices completely independent of the patient's insurance or whether they're insured at all. And we just respond to the needs of the patient and the primary care practice and have no other incentives or agendas other than that. And I will say that as a psychiatrist, I really enjoy practicing under this model. I feel like I'm practicing at the top of my license. So does my care manager. Documentation is focused on what the primary care doc needs to know and not on billing, and it's fun. And you can do the same thing for any specialty that across a whole array of specialist consultations. Also, the collaborative care teams can determine when a specialist referral or trip to the ER or hospital is truly medically necessary, which could replace utilization management by either a Medicaid department or insurance companies. And it would be much more accurate and effective. It would be much higher level of expertise brought to bear on medical necessity determinations. So what about Kaiser? Medicaid deprivatization would eliminate capitated contracting with health plans. But Kaiser Medicaid patients could be accommodated by simply paying Kaiser for their care with fee-for-service instead of capitation. Kaiser might not prefer that because it isn't their model, but it would work. It could be done. It used to be done in Hawaii before Medicaid went under managed care. If a Kaiser member went on Medicaid, they would just accept fee-for-service payment. So there's nothing to prevent this from being done if we were to deprivatize Medicaid. And also, if some specialist services were not available within Kaiser, they could easily be provided to Medicaid beneficiaries outside Kaiser because they wouldn't be locked into a capitated contract. So the PNHP report, which was linked on the flyer for this talk, and it's also, the link is in the next, or a couple of slides later than this one, did a detailed review of all available literature and evidence on Medicaid managed care, and a lot of discussion of what Connecticut did, how they did it, where they got their savings from. And it also has a table for what each state could save if they did the same thing Medicaid did, and going to non-risk administration by an administrative services only contractor, and enhancing primary care pay and community-based resources. And the annual savings for the state of Washington would be $757 million plus to $1.287 million, or $1,287 million plus. And the lower figure is if you only got the administrative savings from going to non-risk administration instead of competing managed care plans. And the 1.2 billion figure is if you did all the enhancements to primary care pay and community resources that I just described, you could expect savings in that range. So what are the alternatives that a state could do in response to the January 2027 federal cuts to Medicaid? Cut Medicaid eligibility, cut benefits, cut doctor and hospital fees. All of these would increase uncompensated care or cut reimbursement, putting even more pressure on our struggling primary care practices and hospitals, especially rural critical access hospitals. Removing the middlemen would accomplish all of improved primary care pay, reduced administrative burdens and overhead for doctors, improved access to care for beneficiaries, and save up to $1.29 billion per year for Washington Medicaid. I don't know how you get this through the thick skulls of your legislators, but they'd be crazy not to do this. So these are the PNHP report, fee-for-time proposal that was reviewed in Health Justice Monitor in July 2023. And I have an overview of, it started out as what legislators and policymakers need to know about health policy. It was published in Counterpunch last May. So you're welcome to copy those, or if you get the PDF of this, you can just click the links. Okay, I'm open for questions or discussion. I will say right off the bat, Chris Curry has in the chat, can you share how you arrived at the Washington State savings figures? That is detailed in the PNHP report.
Okay. I didn't see much detail in the report.
Well, the report goes into how they calculate savings, and they say, okay, we'll just apply this to all the states that have managed care organizations, and here's what we come up with. But the methodology for calculating the savings is in the report, and they just took the percentage of administrative savings that Connecticut achieved and what they spent back in improving primary care and community resources, and that's how they came up with those numbers for each state.
Okay, Bruce Davidson has a question.
Thank you. Thanks for that very nice history. I submitted a resolution to the Washington State Medical Association, which they approved to end contracting out Medicare. So the State Medical Association has approved that. And I've read through this bill, Senate bill, and just make a couple comments. One, there is $10 billion now currently that goes to 5 companies that contract out, 4 of them for profit, 1 not for profit. Their overhead is 15%, so that's 1.5 billion. Connecticut's
It's probably actually higher than that, but that's their reported overhead.
yes, correct.
Yeah.
And Connecticut's overhead is 3% that they report. So that's a saving potentially of $1.2 billion
Yeah.
to do, as you said, spend on the patients and on the people looking after them. Second, Senate bill includes this all being under the Department of Health. In the state of Washington, it's under something called the Healthcare Administration, not the Department of Health. So if the Senate bill weren't changed, that would have to shift the whole process somewhere else. Third, it doesn't require a new law, according to several experts who've looked at it, to deprivatize, to end contracting out. It simply requires an administrative change. Fourth, in the state of Washington, anyway. Fourth, this coordination of care and minimizing subspecialists, seeing patients and so on, I would hope the bill would drop that and you would drop your advocacy of that, because deprivatization is a big, big deal. And I personally think poor patients should be able to see subspecialists same as wealthy patients do. And the coordination of care is already a part of Medicare and Medicaid. There's a CPT code for it. Medicare pays for an hour of coordination of complex care about $140. And for an extra 30 minutes, it pays $70. So I would not create a whole new business of coordination of care and a whole new infrastructure. And that's what I wanted to share. Thank you.
There's something I wanted to comment on. What was about your third point?
Well, I talked about coordination of care. I talked about the health department versus HCA. I mentioned what the money.
Oh, I know what it was. It has to do with the state can do it directly, which is Medicaid is under the administrative department purview. So that is correct, but the legislature can pass a bill that would force the administration to deprivatize. And they can also pass any other bill that would regulate how the state administers Medicaid. And then you need more legislation if you want to change that in the future. So if your state has not yet got a bill to regulate Medicaid, then it's true the administration can just change it. But once you do pass a bill, then you have to involve the legislature to change it again. I do think that my experience with specialist consultations is as I said, we did it insurance blind. So we didn't do it just for Medicaid. We did it for everybody. And we referred patients for direct care with a psychotherapist or psychiatrist when we felt it was really necessary. And if the problem could be managed in primary care, we would tell the primary care practice how to do it. And the primary care practice experienced this as a relief because they didn't have to worry about spending huge amounts of time trying to figure out what to do with a problem they were uncomfortable with. They had somebody basically holding their hand, telling them exactly what to do, and they would just do it, and the patients would get better. We have exemplary results in reducing PHQ-9 depression scores and anxiety scores and keeping people out of the hospital and keeping people out of the emergency room. And the primary care practices at first were kind of skeptical, thinking, I just want to get rid of this patient. I want the specialists to take over. But once they started using us, they love the model, and they started enjoying dealing with psychiatric problems because they were now confident they were doing the right thing. And if it got too complicated, we would take them off their hands, and we would help triage the direct referral. So it really enhanced access to care to specialists across the board. It really leveraged my time to cover a much larger patient panel than I could with all direct care, where my practice would just fill up and then I couldn't take anybody new for a month. So it works well all around, and it's certainly not second-class care for the poor. It's a model that should be applied for everyone.
Well, rather than debate withholding subspecialty care, let me just say that I would remove it from the issue of deprivatizing Medicaid because it's a separate thing and it could be instrumented down the road if that's were to happen. But at this point, you have the state's physicians supporting ending contracting out Medicaid. And I think that's a tremendous initiative that I hope this group would go forward with that and deal with the nuance of starting new programs and so on down the road. Thank you. I'll stop there.
Okay, I do think that if we're going to deprivatize Medicaid, you want to do it as cost effectively as possible, and would play a role in making it as cost effective as possible, and that's why I'm proposing it. But I would rather have it statewide too. I would rather have every state have all insurers contribute to a program to provide it independent of insurance status. But you have control of Medicaid, so it's possible to do it in Medicaid as a starting point and then expand it from there by showing that it works. Catherine.
Yeah, Bruce's question was kind of my question because I had read the email that he was his objections towards that. And anyway, I just want to say that I really like this care collaboration, even though I know in our bill they put care coordination. Also, I was pretty upfront with the senator's office when we wrote that bill that I was not exactly certain, because I tried reviewing the RCWs and stuff on who exactly oversaw. I thought it was the HCA, but in some areas it looked like it was the Department of Health. And so I put it in their hands to determine who exactly it was. But so that's all I know about that. Anyway, and I don't think that it matters so much anyway, because that's just really an administrative thing that they can easily figure out. But one of the things I like about that care collaboration model is I really feel it helps to be able to expand the specialty services where there's shortages, especially in like behavioral health. And I feel like even it was, and I don't know if I wrote it wrong or we wrote it wrong when we wrote it, because I thought I tried to use your language of care collaboration rather, but it got put in as care coordination. And I think we need more education to physicians and definitely the legislatures. They don't know jack, but on what that care collaboration model is. I would hope that they would be excited to try that since it came from the UW. Let's claim
yes.
Yeah.
In the Hawaii bill to deprivatize Medicaid, we didn't get into any detail about specialist consultations. We just said community resources could include specialist consultations without saying anything more about it than that. But I'm saying I think it would enhance the system to do that.
There was one other complaint I omitted, and that is that this bill includes pre-authorization. It just says AI can't do it. And I want you to understand that Medicare has no pre-authorization until they just added it this year for certain procedures. So Medicare doesn't do that. All right, Medicare, after it's already done, if they don't like it, they can deny it. So I would remove that. I would not institute that in a fee-for-service Medicaid when Medicare doesn't do it. Thank you.
Medicare does do limited prior authorizations.
So it's Medicare.
But it's for things that are blatantly not for legitimate medical purposes, like taking modafinil for truck drivers so they can stay up for long hours, things like that. They won't allow. So they do prior authorize a few things, but it's far, far less than with Medicare Advantage or Medicaid managed care. But there are some legitimate places for prior authorizations. I don't think you should ban them completely, but you do want to make them as minimal and judicious as possible.
HCA can decide what they want to add, but to put it and authorize it in your bill is to do what the Medicaid Advantage plans are doing. And I sure wouldn't do that to doctors and to the nurses and all the folks looking after these patients. Over.
Okay, David?
Yeah, I just wanted to have you say something about cherry picking and lemon dropping that you talked about early on. And can you give some examples of that? Because it doesn't, I don't think everybody here knows exactly what you're talking about there, but this is pretty typical for privatized Medicare Advantage, and would be for privatized Medicaid too. Or so what is cherry picking and lemon dropping? Can you give some examples?
In Medicare Advantage, it's much more of a problem than Medicaid managed care because Medicaid is a high-risk program across the board. And when you have several managed care plans that are the only game in town, they're not competing with fee-for-service Medicaid. And you often have random auto assignment for if patients don't choose a plan. So everybody gets stuck with their share of sick people in Medicaid. But in Medicare, they're able to market to the healthy and have policies that discourage or interfere with care for the sick, which drives the sicker people out of Medicare Advantage and back to traditional fee-for-service Medicare. So you get a sicker population in fee-for-service Medicare than you do in Medicare Advantage. And they do it both by attracting the healthy out front and by pushing the sick out on the back end when they get sick. But I don't see that much in Medicaid. There's high risk is spread all over the place in Medicaid. Chris.
Yeah, I think states still think that capitation helps them with budgeting and long-term financial security. So could you explain a little bit more about why that doesn't work and what you mean by establishing a separate risk pool?
The two problems with capitation are that it has perverse incentives and that it has high administrative overhead. The administrative overhead is much higher than with paying fee for service. And when you get studies showing savings for Medicare from capitated plans or from alternative payment models using capitation, they never tell you or they never look at or consider the administrative cost to run an ACO. If you're running an accountable care organization paid by Medicare with capitation, and then you have to pay the doctors and hospitals for the patients that are in your ACO, you have to worry about risk management, which really boils down to trying as best you can to cherry pick and lemon drop and upcode and things like that. That's what it really boils down to. But you need all this data to do that. And you have to collect that data from your doctors up front. They have to submit quality metrics. They have to submit detailed diagnostic information in order to be able to manage the risk that they have taken on by being capitated. And
But
the risk comes from having defined members.
Doesn't the contract deal with that? I mean, if you're going to establish a contract for a certain amount of money for a year or 2 years or whatever, then that's the amount of money the state's going to pay, regardless of how they.
If you're running managed care plans, your contracts have to deliver you that 13 to 20% overhead, and if you're directly paying providers with fee for service, your overhead is in the range of 3%.
Okay, so it's the predictability is there, but the expense is higher.
The predictability is also false because the predictable thing is the cost for medical care for a year is fixed for a year. But what happens is that once you contract care to a managed care plan, The managed care plan has the state over a barrel, and they can get whatever raises they want by manipulating the data they give to the state. And they do this. We have the information to prove it. They do that so that they're able to command, an 8%, 12%, 15% raise year after year by giving the state data to show that they need it. And in Hawaii, our Medicaid costs were tracking exactly the national average until we did managed care in the mid-90s, and then they started rising 3% faster than the national average. So the idea that budgetary predictability is an advantage is an illusion. The most important thing for budgetary predictability is the size of the risk pool. The bigger the risk pool, the more manageable the variability is. So if you already have the whole Medicaid population, you already have the best situation for managing risk. If you break it up into a bunch of competing managed care plans, each of those plans has higher risk, has to manage higher risk, and they have to charge you for that. So you're paying extra because you fragmented the risk pool.
Yeah, thanks.
Okay, Ronnie.
So, Dr. Kemble, I wanted to thank you for inspiring us to take advantage of that or to look into that coordination of care model. The University of Washington Center, the AIMS Center that does the behavioral health programs, is going to be giving a presentation at one of the Healthcare for All Zoom meetings in April or May, and going to them, I would certainly hope they'll explain some of the funding that makes that process happen. One of our board members is a psychiatrist that worked with the UW program, just like you've done in Hawaii. So I wanted to thank you for that, and also to share that when I mentioned your name, they said, "Oh yeah, we know Dr. Kemble and really appreciate his work." So not only did you call out the UW program, but they recognize you powerfully. So you've had a meaningful impact on their program. So thank you for that.
Oh, thank you. I'm on a listserv for doctors participating in collaborative care with UW. And one thing is that we're the only place that does direct funding. Everyone else uses CMS procedure codes. And across the country, most programs have trouble covering more than about 80% of their costs using those procedure codes. Because we don't do any billing and collections cost, we've been able to cover 100% of our costs. Some plans pay us on a case rate basis, and they pay us the same as they would have paid if they were using the fee-for-service code, but they pay us directly, and we don't have to bill anyone for it. And that covers our costs 100% and enables us to deliver our services independent of the patient's insurance status. So I would say that direct funding is at least 20% more cost effective than using those fee-for-service codes that CMS has set up. But no one else in the country has had the nerve to try to negotiate with all the health plans in their area to get them to contribute directly. If you have a single Medicaid program, you could do it easily within Medicaid because you have one payer.
Okay, David Lau.
Yes, Dr. Kemble, thank you so much. A question about Connecticut. When Connecticut deprivatized Medicaid, what happened to the 340B pharmacy savings that accrued to the community health centers? What happened? Was there any change in how that worked?
That's a good question. I think they deprivatized it before the 340B program reached its current form. So I think it's more of a problem now than it was then. I don't recall the solutions off the top of my head, but I do have I have a file on my computer with suggestions for dealing with 340B if you deprivatize Medicaid that I could dig up. But it is a problem, and there are workarounds to try to address it.
That would be very helpful if you could share from that file. If you want to send it to David McClanahan, that'd be fine. But that's an issue that is facing us here now, one of the many issues.
That's a good question. I'll send what I have to David then.
Thank you.
I'll also send a PDF of the slides.
Okay, Catherine?
Yeah, I also have had another question that I didn't know the answer to, and maybe somebody here does know it. When Connecticut deprivatized, do you know how long that process took for them to actually complete it?
Yeah, they made the decision early in 2012 and implemented it in January 2013. And the reason they were able to do it pretty quickly is because they used a former managed care plan as their non-risk administrator, and that plan had all the systems in place to do what they needed to do to run the Medicaid program because they were already doing it for a part of the Medicaid program, and that meant that their transition could happen pretty rapidly.
Okay.
I'd also mention, Catherine, that the state HCA currently does 8 billion or 9 billion of payments, including payments to hospitals that some of the managed care folks don't do. So that the state HCA is already experienced with paying those bills.
Right.
And the state uses blocking on a name, but they use another company to look at the bills and pay them monthly, an auditing type company. So it's going to take more infrastructure, but it's not going to take $1.2 billion of additional infrastructure. Over.
Right.
Was that,
Thank you.
excuse me, Dr. Kemble, was that the legislature that took action in Connecticut, or was it their healthcare authority, or?
No, the administration did it.
Oh, they did, okay.
But I think when you say the administration, you mean the governor?
Yeah, the
Yeah.
governor, the legislature were on board with it, but the governor was the one that made the decision and
Right.
implemented it.
Okay.
Okay, Sherry?
Oh, hi. I wanted to know, is there an estimate cost to implementing this firing of the MCOs and Medicaid? We talked about that before because during this legislation, they didn't want anything with a price tag on it. And then do we have to have a specific state study to get legislation? Or can we use the resources you provided and that should be adequate for legislators to just
Well, the state will have to have some administrative costs. They're going to have to develop an RFP to hire the non-risk administrator. They can have that administrator to do most of the administrative functions, but they're going to have to provide some oversight and they're going to have to set it up. So there will be some effort on the state parts. The managed care plans, all you need to do is terminate their contracts. And you hire one of them as your non-risk administrator so that you can have a pretty seamless transition. But basically what you're paying the managed care plans goes away. You then have to pay your non-risk administrator whatever that's going to cost, which in Connecticut's case was 15% of the cost of the managed care plans. So you'd have immediate savings. You invest some in hiring your contractor. You invest some in improving primary care pay. And you still end up about 10% less per person than you had before with managed care plans.
Great. And then Connecticut had the legislative support, and if we don't have it, then we just hopefully get it and then just come up with a figure. Do you feel like we need a state research that says you would save this exact amount of money, or can you take the research from, the stuff that PNHP has done or you've done?
I think that it's hard to come up with an exact figure. Anything you came up with, even a detailed analysis, would be a guess. But the PNHP report is as good a detailed analysis and a guess as you're going to come up with. So I would just use that to say you're going to get some savings up front from administration. And
there are auditing reports that currently exist that show the roughly 15% that the other companies charge.
Yeah.
And Connecticut documents it's 3%. And as Dr. Kemble pointed out, the other companies say it's only 15%, but that's because they put additional administrative costs in their alleged health care. Now, you could put obstacles in front of this by saying, oh, we need a cost report and we need to show feasibility and we need to have a legislator get on board. But if you're sincerely in favor of this, you don't need to put any of those obstacles in front of it. You simply have the governor direct HCA to do it. Over.
That's correct.
Thank you. Let's do it.
And we have leverage now because you have the Medicaid cuts coming up in a year, and because at least most places in the country have severe doctor shortages, and we're losing doctors faster than we can train them because the practice environment has become so toxic. So something that improves the practice environment for doctors and saves money for the state, both at the same time and to a substantial degree, is a powerful motivator to say, we need to do this and we need to do it urgently. It's hard to get some people to listen, but those are the facts.
And you also have the state medical society, that is the state's physicians, endorsing doing it.
Yeah. I think widespread physician support will be a big help in getting something like this over the line.
We have that in Washington.
We have a trifecta, but that doesn't mean they're in support of saving money on healthcare.
No, I mean the medical society.
Societies,
Oh, yeah.
We
I
do.
think they have endorsed it, right? Is what I
They
heard.
resolved it. Yeah, they passed my resolution that I and Dr. Connolly put forward to do it.
Great.
And we gave a rationale for it. For example, the previous head who resigned January 2025, the head of the HCA, was paid like $230,000 to do that job, and meantime held 2 other jobs. So that was that, and the savings are compelling. And so have the physicians on board. I wouldn't put any other obstacles in the way. Over.
Yeah, I have a question. I think Washington State has a bill for deprivatization of Medicaid. I think Catherine or Carrie know the number of it. Was it Bob Hasegawa or somebody introduced it, but no co-signers, and it's not going to go anywhere.
Nobody.
It's not going to go anywhere this year, and hopefully maybe next year. But are there any other states that have bills that are in their legislatures that they could be voting on? Maybe New York Health Act or something like that.
I know New York is working on it. Minnesota has a bill. North Carolina is working on it. I know there's interest in Massachusetts, other states, but there are several that do have bills that they're working on getting introduced.
Oh, that's great. Great.
Is that specifically for getting the MCOs out?
Yes.
Okay.
Yes.
We have a Senate bill, and we are speaking with our potential House sponsor so we'll have an opportunity to get co-sponsors for a House bill here very shortly.
The Hawaii bill is being. I just got the copy of the bill after it was drafted by a legislative aide in proper format, and it's being introduced by the chair of the Senate Health Committee, so that will be helpful.
And to be honest, one of the things that one of our Republican health care committee people told us last year when Carrie and I met with him was that no physicians were coming to him telling him that there was any kind of a problem. So I really think we need to have a lot of support from physicians going and speaking to some of the legislatures down in Olympia, because they think y'all are just happy as clams down, in Washington.
Well, you can show them the resolution.
Yes.
They're busy in practices.
Is it
Sorry?
published?
I'll send it to you.
Awesome. Thank you.
Right.
I'll send it to Catherine, let her send it around. Okay, I have to go.
Oh, good. Thank you.
Yep.
And then, Dr. Kemble, did you say that this is available? You've got this slideshow. Is this the same one or different than the last one? I think
I haven't done this for Washington. I did something similar for Oregon, but it's not quite the same.
Oh, okay.
But I'll send a PDF of the slides of this one. I hand out 6 slides a page.
Yeah, that'd be great.
I'll send that to David.
Yeah, and then he could send it to all of us. That'd be great. Gosh, that's so helpful.
And also the 340B question was the other thing I'm supposed to send. Yeah, you can use that as a handout for legislators too.
Yeah, thanks a lot, Steve. That was very helpful. I would agree with Dr. Davidson that the majority of people in practice, I mean, I think this just sails over their head, and it's just the annoying background that they are so busy contending with day to day. And Bruce, I don't know what the WSMA has done, or have you done grand rounds for the university or whomever? But I think it would be great to help get your information for your proposal out to as broad an audience. And maybe it's just me not paying attention, to be honest.
I think Bruce signed off.
They, yeah.
Oh, yeah, he did.
I looked at that report, Catherine, and others on PNHP, and it's very interesting. I would highly recommend it. There's a chart in there that shows state by state analysis of the money that it would save. And it would really be significant. Also, I don't know if everyone's aware, but there are 6 different corporate entities that are currently MCOs for the state of Washington Medicaid. So it's already kind of a Byzantine mess. Molina is probably one of the best known. But there are I think 5 others that have their fingers in the pots too. And I agree with Dr. Davidson and Steve completely. I mean, Health Insurance 101 is a big risk pool, and that was the big failing of the HCA was to take a huge risk pool and just divide it into thousands of risk puddles. It just doesn't work.
Yeah.
Hey, David Loud.
Yeah, I just want to point out that one of the managed care plans in Medicaid in this state, the only nonprofit, is the Community Health Plan of Washington, which includes all of the federally recognized quality community health centers.
That's the one you want for your non-risk administrator.
There you
Well,
go.
I love that idea.
Yeah.
But I do know that there are some concerns, I think, with that MCO in particular, because some of their savings or something goes back to help support the rural hospitals. And so they're worried about that. But I'm thinking to myself that those issues would be completely resolved with a global hospital budget.
No, it's not the hospitals, Kathy. It's the savings from the 340B pharmacy program that the Community Health Plan of Washington redistributes to all the community health centers.
Okay.
It goes to the community health centers, not the hospitals.
Yeah, you can't do global budgeting of hospitals if some of their revenue is global budget and some is fee for service, because the global budget is paid up front, so they're already paid for those patients, and the fee for services, they get paid as they go along. So their incentive is to maximize services to the fee for service people at the expense of the global budgeted people.
Yeah.
So you can only do global budgeting if you got the whole pie.
Well, I know in our Washington Health Trust, any nonprofit hospital has to be funded through global hospital budgeting, which would put everybody under global hospital budgeting. And honestly, I have to say that I'm like, now that I'm done with this master's in legal studies, I'm focusing on trying to understand global hospital budgeting better. But my understanding is when they still use that fee for service to kind of help understand the global hospital budget that the hospitals would need. What else was I going to say? But anyway, I think that the problem goes away, So right now they're getting the extra money from that savings. But I was looking at Mark Cuban's, discount medication program and the savings that he talks about and everything. And I thought these are the kind of savings that the state could also also achieve themselves by buying wholesale, and distributing. And so the savings would still be there. The potential is still there to support these rural hospitals if we just think about saving money rather than giving profits away to people who don't really appreciate it because they take advantage of it.
David McClanahan and I can attest to the fact that a mixed model of managed care and fee-for-service is a thrash. And that's what, when the Public Health Service Hospital in Seattle closed down, it became the Public Health Authority, famous, now Pacific Medical Center. It was almost an impossible task to have that blended model just from the aspect of provider compensation alone. It's very, very different because they're just antithetical in the way that it works. And I think it's fascinating, all of the bad mouthing against fee for service. The fact that the data doesn't back that up, Stephen, that just kills me.
Right. Well, see, that's my frustration too, though, because I mean, all the models that I looked at use fee for service kind of as a base, but for some of those rural hospitals, they're not going to have the volume to be able to, on a fee for service basis, to be able to cover the expenses of maintaining a hospital. And yet those people deserve care. And when
Right.
I go there and if I get hurt up in the mountains, hiking or biking or riding my horse, I want a hospital to go to.
Yeah, that's a
You know what
very
I mean?
good point.
Yeah.
You've got to have a certain baseline budget to keep the doors open.
Right.
One of the advantages of having a large program like Medicaid as a unitary program is the Medicaid department can set aside a certain part of their budget as subsidies for those rural hospitals.
Mhm.
You don't have to lock everything and only paying with fee for service. You can have part of care paid fee for service for all the independent practitioners, and part of it paid with budgets for the community resources, and part of it is supplementary payments to your rural hospitals to keep them afloat.
Mhm.
And did you say
Well-
that's traditionally managed by the healthcare authority?
Well,
Medicaid?
I tell you, when I tried looking it up, it got me confused because it appeared to me that there were some aspects that were overseen by the Department of Health and some through the Healthcare Authority, and that's why I asked the Senator's office. They told us we didn't have to worry about those details, that they would do the research, and so I kind of left it. I couldn't figure out where the line was on a lot of which department over was the top dog.
Hmm.
So, but we were under a time crunch too.
Mhm.
So if that's wrong, it can just easily be changed. To me, it's not a roadblock or anything.
Well, I want to say, first of all, thank you so much, Dr. Kemble, for doing this, leading us through this. It's been very educational and stimulating a lot of thinking and questions and thoughts about how to go about doing this. And I think the making it clear that doing this for Medicaid is a step in the direction of single payer.
Yeah.
That when you get a huge, Medicaid is what, 25% or so of the population? When you get them if we get all of Medicaid under a single payer plan, it allows all the infrastructure that's needed to run a single payer plan to develop, and then expanding it by adding more groups will be a way to get to ultimately a nationwide single payer plan. So it's been fascinating and fun for us. Some of us, like me, have been in this fight since the late 1980s,
Oy.
which is a while ago. It would be nice to get there.
I can say when I edit this, I can slowly roll through it and try to figure out what people were saying because it's really complicated for an old man like me to try to figure out. So hopefully let's see, by Friday or so, I'll have it up on our YouTube channel.
Great.
And
And
yeah, thanks so much, Steve. And
yeah,
Welcome.
you're one of our heroes, guy.
yeah. And Dr. Kemble, have you seen our bill, the Washington, it was a deprivatization bill?
Yeah, David sent it to me a couple of days ago. I did see it's pretty similar to our bill.
Okay, we were just hoping it helped.
I know on the prior authorization question that Dr. Davidson raised, our bill says it has to be used as judiciously as possible, but it doesn't sort of just say prior authorization is okay. It says it's allowed, but it has to be used as judiciously as possible.
Thank you.
I think it was somebody in the stakeholders group that was really worried about the AI. Damn it. But Anania has got his hand up.
Oh, I'm sorry, I didn't see that. Go ahead.
Thank you. Steve, I think this was a very exceptional presentation, and I think the energy reserve was very exciting. I just wanted to ask a clarifying question. So is the Medicaid deprivatization going to be a campaign that Washington PNHP chapter is going to be working on going into this year?
Well, I can say healthcare is a human right prioritized it at their last meeting, and I think a whole lot of organizations in Washington State we're pretty good at collaborating with each other, and I think we're going to be focusing on that over the next few months.
Exceptional. I look forward to working with you guys to not just have Medicare for all deprivatized, but to also have a Medicare for all like nationwide.
So you should tell us that you're from PNHP National Office, organizer in charge of our Western territories here, right?
I'm the national organizer that's going to be working with the Washington chapter. The thing that I'd love to see is to help this chapter grow and win on the campaigns that we need, and to be building the powers that we need at the city, state, and federal level to have us have a single payer system that is going to treat everybody with respect and dignity when it comes to our healthcare.
Great.
So I don't know if I'm like the supervisor, but I'm hopefully going to be a helpful asset with any and everybody here.
Yeah.
Yahoo.
Great to see you.
Yeah,
Yeah.
glad you
Yeah.
could make it.
Thanks for coming.
And go Seahawks.
Well, I don't know. He's got split loyalties. He's a Denver guy.
I'm a Denver guy. So,
Yeah, we
Yeah,
are.
we have
Yeah.
another round to go before they play each other. Okay, everybody done? Are we ready to sign off for the evening?
Yes,
Yeah.
thank you so much.
Yeah. Thanks, everyone.
Thanks, Steve.
Nice to see you all.
Yeah,
Okay. Nice.
Keep hope alive.
yeah.
Yes,
This is
Yes.
really a great presentation here. Thanks again, Steve.
yes.
All right, so we'll
Thank
go
you.
5, 4, 3, 2, 1. 5, 4, 3, 2, 1. Bye-bye.
Bye.